Thank you all for joining us here this morning. My name is Jeff DeBelko. I have the good fortune of directing our Environmental Change and Security Program and coordinating our Global Health Initiative here at the Wilson Center. It's a great pleasure for us to be hosting this session that we've entitled Designing Health and Population Programs to Improve Equity, Moving Beyond the Rhetoric. And I should say, it is not just the Wilson Center. We are very pleased and thankful to be collaborating and co-sponsoring today's session with MCHIP program. It is obviously one that brings many of us together and that we look to for leadership in this topic in this area, and so it's terrific to be collaborating with them today on a topic that around equity that we have the good fortune of working on here at the center as part of our HELPS project, which is Health, Environment, Livelihoods, Population, and Security, which is a mouthful, but one of the things that we're focusing under this USAID Office of Population Reproductive Health Supported Program are the GLPs, and equity, of course, is one of them in the context of family planning and reproductive health. And so bringing that together with our other under Global Health Initiative focus on maternal health with a monthly maternal health series supported by UNFPA and the Maternal Health Task Force, we have a lot of stars aligning under the rubric of the discussion that we have today. We have an old friend to the program and to old friend of mine, John Borrazzo, who has agreed to be our captain and our navigator today. John, as you know, is the chief of the Maternal Health and Child Health Division in the Bureau of Global Health at USAID. So as to maximize the time we have to hear from our distinguished guests and engage you in Q&A, John, I'm going to turn the floor over for you to make the introductory remarks.
All right, thanks very much, Jeff. I'm going to keep my remarks very short, and I apologize we started so early this morning. A number of us are involved in a maternal health portfolio review agency-wide major event starting at 10:30, so I'm going to have to leave at 10:15. In the interest of, since we have a relatively short amount of time, and we're not going to go around the room, which is oftentimes typical in this smaller Woodrow Wilson Center format, but rather jump right into what we're trying to get at today, which is looking at this issue of equity and how we can do a better job effectively integrating equity into our programs, both understanding it as an issue, programming towards equity ends in terms of reducing inequity, whether and how we can use those kinds of programs to meet our country level and national goals, and finally, how do we actually measure that we're making progress. We have 4 great speakers to address that. They've all been looking at it from different perspectives. Those speakers include Mickey Chopra, Dave Gwatkin, Cesar Victoria, who is here in an electronic format. It's almost like having him really here with us. Isn't this great? And Jennifer Luna. So without further ado, I'm going to introduce the first speaker. That's Mickey Chopra. Mickey is Chief of Health, and he's Associate Director of Programs at UNICEF's New York headquarters. Previously, he was Director of Health Systems Research Group for the South Africa Medical Research Council. He's worked as a district medical officer in rural health districts in South Africa, and he has published over 70 international peer-reviewed publications and contributed to numerous book chapters. So he's well positioned, and I have to say we have heard this case that UNICEF's laid out last year about equity being a critical issue if we're actually going to achieve MDG 4. And I found the case quite compelling, and we look forward to hearing what you've got to say, Mickey.
Thanks, John, and good morning, everybody. And thanks for making it this morning. And thank you to the organizers for inviting UNICEF to present. And what I want to present today is actually building on the work we did earlier, which was to really do some modeling work to establish that reaching the poorest and the most marginalized had now come to a point where the massive benefits that can be gained from some of the interventions we have and the innovative ways of delivering those services have now outweighed some of the extra costs of going that extra mile. And therefore, we were able to show, and we'll be publishing soon, analysis showing that it's actually more cost-effective to have an equity-based approach. So it's not just right in principle, but in practice. And what I want to do today is just take you to the next chapter of our thinking and to share with you and look forward to some of your reflections on how do we translate an equity approach into thinking about strategies and strategic investments in our programming work, because we're now working with our country offices and programs across the world and with partners to start to think about more systematically about how do we analyze the situation and make the best advice and way forward in terms of making programming and equity a reality. So the first part of my talk will just be a brief overview of the equity question and challenge, and then I'll go more into some of the strategic ways in which we're thinking about it. So just to remind you that we have made good, this is MDG 4 now, that we have made good progress, but that if we're going to, and sorry, the 2000, this is the wrong slide slipped in, the 2009 one is showing about a 20% decline. So we are making progress, and there's been an acceleration of progress as well. But there has to be a step change if we're going to get to the MDG, even for MDG 4. And the other point I want to show to you on this slide and point out to you is that those gains are happening in particular in Southeast Asia with Bangladesh and India and parts of India and China, whereas Africa has more or less remained stagnant. So there are some inequities already in terms of progress and rates of progress. I won't have time to go into detail this slide, and hopefully many of you are familiar with it by now, and I hope this is the pointer. Yeah, so we looked at about 35 countries which had made the most progress in reducing infant mortality in the last 10 years, and what we found was that 2/3 of those countries had actually increased inequalities between the lowest quintiles and the richest quintiles. In other words, the progress had been captured predominantly by the richest and better off quintiles of the population. However, there were a minority of countries such as Ghana and Eritrea and Nepal and Malawi, which had actually made progress and reduced inequalities, the difference between the richest and the poorest quintiles. So, progress is not necessarily at the expense of the poor. It is possible to make fast progress by reducing inequalities. And the predominant way in which these countries, when we looked at their policy analysis, had made that progress in an equitable manner was to really focus on ways of delivering and getting these critical interventions to the marginalized and the poorest first through community-based programming, through strengthening primary level care and other interventions. I'll come back to that shortly. Just another illustration of how, if we're not proactive and looking for it and thinking about it, that there is a tendency, and this is an example of stunting from India, just showing the changes in stunting levels over the last 13 years, and how the rates of progress have been much faster in the better off in India in this example. And there are numerous other examples, and David here on the panel, Dave has actually been at the forefront of really bringing that to our attention, of how the middle and classes in particular capture even some very pro-poor types of interventions such as ORS. And of course I forgot Cesar's on the panel as well, and Cesar has also with Dave been at the forefront of this kind of analysis. So one way to think about how we should think about the programming is to think about the uptake that we have amongst the better off and the uptake we have amongst the poorest in the population, and how if we could close this gap between the gap between the uptake of the richest and the poorest is where we could be saving thousands if not millions of lives extra. So the challenge at a programming level and a policy level is to understand why there is this gap between the rich and the poor and uptake of the most critical cost-effective interventions that we have. And our analysis is suggesting that there are three broad areas to focus on. It's looking at the way the services are delivered. It's looking at and financed. It's looking at the way in which individuals and communities are empowered, have knowledge, have the capacities to maximize the utilization of these interventions. And then it's to look at the policy, legislative, and macro level factors which are shaping the other two factors. So what we're now sort of starting to work with our country counterparts is to say, these are the kinds of broad areas that you must examine to see what the reasons to explain and close this gap that we have between the poor and the rich. So I just want to take you through some of the thinking, in particular number one. We're a little less advanced in our thinking around number two, and the one around the policy and legislative it's been shaped by this analysis, but ultimately also our thinking around empowerment and capacities of the user as well. But let me focus on the delivery side and equity thinking in terms of delivery systems. Our starting point is the fact that we do have a number of critical, cost-effective interventions which could make a huge impact on lives saved. So these range from acute treatment types of things, such as ACTs for malaria, emergency obstetric care, and so forth, through to more chronic types of treatments, down here, through to preventive interventions, which are either once-off or short-term, such as PMTCT, or things which are more long-lasting and longer, like EPI. So every country should have, the first phase of the equity work was to really look at the epidemiology and make sure that we've prioritized the diseases of the poor and got the packages and policy changes to have the best interventions in place. But the next step after that is to think about how those services are delivered. And we've identified three major ways in which services are delivered. The first is your clinical services mostly. These are characterized by high asymmetry of information. You need to have a skilled professional or health worker who needs to get very specific information from the client to be able to make the best intervention. And these kinds of services and ways of delivering have quite common bottlenecks in most countries to reach the poorest, in particular the lack of skilled health workers and issues of quality and cost of providing these kinds of services. Here is an example of the kinds of bottlenecks that we see in countries for the delivery of these kinds of services. And what we've been doing through our bottleneck analysis is basically having 5 or 6 critical indicators ranging from the supply side indicators through to some of the demand side as well. So access, utilization, and so forth. There are 2 other ways of also delivering services, though, which we mustn't forget about. One is our outreach and campaign approaches. These can be used to deliver services which require less transaction intensive. They don't require context-specific information necessarily. They're quite often standardized types of interventions. Immunization is perhaps the classical one of the types of services which are amenable to this way of delivering services. And once again, we find some common types of bottlenecks for these kinds of services. And the final delivery mechanism, if you like, is family-based, community-based. And these are where you really is very transaction light. There's low asymmetry of information, and these tend to be the promotive, preventive type of interventions which get delivered through this way. So having very simply identified the main ways of delivering a service, the next step is then to actually group interventions into those delivery channels. And here we have an example of on this side is clinical services. Along the bottom here are campaign or outreach delivery channel, and here is the community-based delivery channel. And each delivery channel has particular characteristics. So in particular, the clinical one is the one that is the most difficult to scale up quickly and most challenging in terms of reaching the poor, whereas the other 2 can be scaled up and can reach the poorest the quickest, but obviously have limitations in terms of what you can deliver using community-based or using campaign type of approaches. But what this does allow us to do, though, is to then think more systematically, and this is the main point of my presentation now, is sitting with country policymakers and stakeholders and partners is to think more creatively about how we can work with these delivery channels, not just to identify the bottlenecks for each of these delivery channels, which can be quite different, but then to design strategies and think systematically about strategies to overcome those bottlenecks in reaching the poor and the poorest. And in summary, there are three main ways in which we could design and categorize pro-poor interventions using this way of thinking. The first one is the classical one, and perhaps the most important one, which is just to try and overcome the existing barriers within that delivery channel. So if it's user fees and the cost of that, is to look at how to subsidize the cost, how to abolish the point of payment type of approach to financing. Similarly, it may be around lack of skilled health workers or maldistribution of skilled health workers to poor areas. And there you're looking at interventions to encourage and incentivize health workers to move to rural areas or to poor areas. So there's a whole, there's a number of innovations, vouchers, and so forth within just trying to improve the existing delivery channel. But the way of thinking also presents two other options that we may think about. The second is shifting within that delivery channel. So the most classical example of that is task shifting. So instead of a doctor doing a cesarean section within the hospital or the clinic, you can get you can train up a medical assistant, as they've done in Ghana and Mozambique and a number of other countries. So the way to overcome the bottleneck of lack of skilled health workers is that you could change the way in which you deliver the service within the same delivery channel. The third way that we could think about intervening to improve equity and get services to the poor is to actually change the delivery channel that the service or the intervention is being delivered through. And one example that we're working on at the moment with many of you in the room, of course, is community case management of malaria and pneumonia in particular. And that's an example of where we're shifting an intervention which has been classically delivered through a facility clinical delivery channel, which has its own bottlenecks and problems, and we've shifted to a delivery channel which is a little bit easier to scale up and get to the poor than the first one. And so once again, this is where there are other examples. For example, getting commodities such as ORS out of the clinic and more distributed through the marketplace. Similarly, I should have mentioned within delivery channel, you can also look at the public-private mix of things as well. And the other big one is to shift things from this clinical one into outreach and campaign types of ways. And we've been doing a lot of that with vitamin A supplementation and deworming, and now pushing it even for other commodities, bed nets, for example. So they get pushed out of one delivery channel and put into another one, which we feel is more efficient at reaching the poor. Now, this way of thinking allows us to sit with policymakers and present them with looking at what they already have existing and building upon, as we plan for the future, of what is the possibilities of change, what are the policy requirements, legislative requirements and distribution chains that need to be changed in order to shift or to move within a delivery channel. And it has the advantage then of not just starting with a blank piece of paper or coming with a very abstract or theoretical approach to equity, but really a practical programming approach to equity. And finally, it's allowed us to also concentrate our thinking around innovation, and that to work with our colleagues in supply division and with the scientific community to say, well, the innovations that we want to prioritize are the ones which will help us to shift and overcome the bottlenecks, either through shifting within the delivery channel or to shift it out of the one delivery channel into another. So it's really about prioritizing rapid diagnostic techniques. It's about prioritizing simplifying tasks within a delivery channel so that lower level workers can perform those types of tasks as well. And then finally, it gives us a framework for monitoring and providing technical assistance to our country offices and to partners when we have a very systematic and relatively simple way of trying to put all these very complex ideas into reality. So all I've really done this morning is to put into a slide a lot of the work that we do together here with many of you, and many of you are doing already. I just hope you find it a useful way of trying to organize all the different types of interventions and strategies that we have, and I look forward to your reflections and thoughts. Thank you.
Well, thank you very much, Mickey. If nothing else, it just highlights that there needs to be ongoing creative thinking and flexibility in terms of our approaches to this problem. So we're going to defer questions and answers until all four speakers have presented. So our next speaker is Davidson Gwatkin. Dave is a senior fellow at the Results for Development Institute here in D.C. and a senior associate at the Johns Hopkins Bloomberg School of Public Health. I became personally familiar with Dave's work when he was at the World Bank as the principal health and poverty specialist, but really he spearheaded a lot of the initial thinking about equity, some of the work that Mickey referred to in terms of the looking at how we dissect what information we already had in the DHS surveys and really looking at it on an equity basis. That was groundbreaking work. I think it's helped to inform a lot of our thinking. He has had he's held positions also with the International Health Policy Program, which is a collaborative effort, and also has served with the Ford Foundation in India, West Africa, and New York. So with that, I'll turn it over to Dave. Thanks.
Thank you much for the very flattering introduction, John. Let's see if I can live up to it. My topic is much the same as covers some of the same ground as Mickey's. It turns out by fortunate coincidence or because great minds think alike that they are really quite congruent. And it's how do you go from this question of talking about equity in general terms to getting something to happen in country programs. And I've got three parts to the presentation. First, conclusion, because I don't like to keep people in suspense. And second, I'm going to talk about some of the techniques that are available. And third, an illustrative process for applying these techniques. And I'll explain those in a moment. Conclusion. It's more promising to try to design a process to fit techniques to country settings than to focus on the techniques themselves. And by techniques, I mean things like user fees, which is the creative, the constant, perennial one, or geographic targeting, focusing on poor areas, or congressional cash transfers, or results-based financing. Those, it seems to me, the problem with those, a focus on those, is the experience that we have with them shows that each one, the variability across countries is very, very large. In some places, a given technique in some situations can work pretty well, and in others, it can be a complete flop. And an example of this is a study done by some bank colleagues where they looked at several 70 or 80 projects, and some of them featured means testing and others featured geographic targeting. And on average, or median to be precise, means testing, about 60% of the benefits went to the poorest 40% of the population on average of the 25 projects or so, which is about 50% more than would have happened through a random distribution. And in some cases, they got up to 80% or more. But in some cases, the poorest 25%, you were down to 40%. And if I'd said the poorest 15 or 20% of cases, it would have been below 40%. In other words, you would have done better off simply by randomly distributing benefits across the population, but then by using a means test. A huge, from 80% to, say, 40%, or actually, if you want to go to your outliers, it would have been from 20% to about 90%. And the same can happen as we go down the list. So it all depends whether a particular technique is going to work. So better, I would argue, to think in terms of a process that can sit down for a particular country and figure out what the issues are, and then work toward the techniques that might work in it. And particularly, as an illustration of this, I don't think it matters that much exactly how one does it. There are many ways one can go about it, but I have what I call here a 5-step iterative procedure to illustrate the point. The first step is to set targets in terms of the poor population group one wants to meet. For example, increase immunization coverage, not overall average in the population, or in addition to overall population, some target for increased immunization coverage in the poorest 20% of the children, say. Or raise attended delivery among women below a country's national poverty line. Now that in itself is not a guarantee. It's appalling how I've had the dubious privilege of looking through a bunch of national health plans over the past couple of months and looking at how their targets are set, and it's really appalling. The targets have nothing to do with the plans. They're just sort of set like this because a donor would think it would look good. And if that's the way one is going to set a target, it's not going to make a difference. But if the point would be to use this as a starting point for the stuff that counts, that is, thinking about interventions and can reach this target. And at least one advantage of having a target is that when you write your monitoring reports 5 years later, you end up writing your monitoring reports in terms of how well you've done among the poorest 20% of the population, and that focuses attention on how successful or unsuccessful one has been. And step 2, which is probably the most important, would be to sit down with people that are responsible and not really understands what's going on in the countries and select a set of potentially pro-poor techniques. And these can be based on such things as analysis of the record and situation assessments. And here's where I think the UNICEF process would come in. That's a very useful, I think, framework for helping guide policymakers through this. Frameworks are great, but you have to apply them before they help anybody. And so national discussions on this would be good. And it would also be very helpful that countries have the record of various kinds of techniques in other countries, both where they have worked and where they have not worked. So getting down and getting a decision made on we're going to do this and that and this in order to reach the poor, and not necessarily 24 things, but maybe half a dozen that people are really committed to and who know their country can think will work in those. Step 3 is, okay, you've decided what you're going to do it. And do it not just in a 50,000 population, but do it in 5 million, 10 million, so that you've got or nationwide if you want, so that you've got a large enough situation to make it realistic and under real operational field circumstances. Step 4 is to find out how well you have done. Monitor the outcomes, because it's very difficult to tell in advance how something is going to work, how any particular poverty reduction technique is going to work. I defy anybody. That's not the way I want to make my money, is by betting on whether some of the things I've recommended are going to work. What I do is I'll say I think there's a better than 50% probability that they will work, but you got to monitor to find out. Now I'm talking about monitoring in a very particular aspect, namely how well your interventions have reached the poor group you're interested in. An example, 3 examples, one from Ghana. These are outcomes. Distribution of social marketing of condoms through commercial outlets. Of all the condoms sold, 75% were in the top 20% of the population. About 5% were in the lowest 60% of the population. There's an illustration of a program that did not reach poor people very well. Kenya, distribution of recipients of measles immunization through a mass campaign, a Kenyan campaign. percent of total immunization recipients were about 20% in each of the population quintiles. So this was pretty well evenly distributed across. That worked much better, obviously. It wasn't pro-poor, but it was a lot better than the average kind of campaign like this works. And Brazil, coverage of subsidized deliveries. There was a study with which Cesar was associated. About, in the poorest quintile of the population, the government was subsidizing about 100% of those deliveries. In the top quintile, it was subsidizing only about 30%. This gradient shows that it was really quite pro-poor. Now, if you want to do this as a separate study, usually it's done as part of a larger evaluation study in which the additional cost of doing this is about zero. If you want to do it as a separate study, probably on the order of $15,000 to $20,000. So this kind of stuff is not a $1 million evaluation, randomness evaluation. It's the $15,000 to $20,000 that could be done in a few months. Step 5, and finally, is if the intervention is working well, go with it. Otherwise, change. A mid-course correction, or just forget about it and start the process all over again. And as the good chairman said, a journey of 1,000 miles begins with a single step. Let's begin. Thank you.
Okay, thank you very much, Dave. I think we see a couple of emerging themes, as you yourself noted, between what you were saying and what Mickey was saying. So we'll pick up on those momentarily. So not finally, but our third speaker is Cesar Victoria, and it says here on my intro sheet that he is Emeritus Professor of Epidemiology at the Federal University of Pelotas in Brazil and visiting professor at Johns Hopkins School of Public Health in USA. The emeritus really surprised me. I always thought emeritus professors were about 75 years old, but I guess that's a little different in this case. Cesar is was one of the coordinators for the groundbreaking and landmark Lancet Bellagio series, Child Survival series, which was in 2003. And in 2008, also worked on the Lancet series of maternal and child health under nutrition. A key thing that relates directly to our topic today is he coordinates the equity working group of the Countdown to 2015. So with that, I'll turn it over to Cesar, and I hope that I think all the technology is working well.
Thank you very much, John. Can you hear me?
Yes.
Yes.
Okay, so Cesar, can you hear us? We've got a bigger issue, I think, right now. So.
You lost him?
Oh, okay.
He's been there.
Yeah, he's been sitting patiently, and the great moment comes. And
Okay, I think we're back on. Are you there, Cesar?
Okay, I'm back on.
Okay.
Thank you very much. Can you hear me?
Yes.
Yes?
Yes.
Okay, thank you very much. Thank you very much, John. You know, life expectancy in Brazil is pretty short, so you get to be emeritus professor in your mid-50s. That's the explanation. Can you show my slides? I wonder if you could move your camera so that I can see my slides. I'm actually looking at the audience right now. And I wanted to address the group about the issue of the MDGs and equities, progress and challenges. Okay, here we go. It's moving. Thank you. So can I have the next slide, please? All know about the MDGs. They were set in 2000, and in particular, the Countdown to 2015 is a global effort to monitor progress toward the health-related MDGs, particularly MDGs 4 and 5. Next one, please. We have had 3 global conferences. First one in 2005, second in 2008 in Cape Town, and next, please. The third one was in Washington about a year ago. I imagine some of you may have attended that conference. It was jointly held with Women Deliver. Next, please. The heart of the countdown are the country profiles, in which we summarize data from 68 countries in the world. This is now going up to 74 countries because we're adding a few more. And these data profiles, which you can see in the next slide, here's the one for Ghana. If you look at the very right-hand side, the last chart in the profiles contain the equity information. From the very beginning, we thought equity was a key component of the countdown. We could not just have aggregate results and coverage or mortality or nutrition, but we did need to have it broken down, at least by socioeconomic groups. We're also working on the equity working group in the countdown in terms of within country regional disparities. We're looking at gender, we're looking at maternal education and urban-rural residents, as well as wealth quintiles. But because we actually don't, we really have to summarize all the information on the country in a single chart, a 2-page brochure. We have to really concentrate and have we can only allow to have one equity chart, and that is the one you're seeing there. I'm going to show it to you in greater detail. Next one, please. So one more. We have started with 2 summary measures, because our key challenge with the countdown and with the equity subgroup analysis is to make sure that we are understood, to make the equity case clearly to policymakers at national and international level. And we do analysis of about 15 different variables. We have actually reanalyzed over 120 DHS and about 50 mixed surveys to make sure that the equity information is now being analyzed in exactly the same way, both types of surveys. But having too much data can backfire. So we're really trying to struggle for a simpler approach to presenting equity information. And the chart you see is not the original chart we had in the first version of the countdown, because in the first version we had it upside down. We had the coverage gap in the bottom and the average coverage of these 8 key interventions, which include preventive and curative interventions. We had the mean coverage on the top. And Jennifer Price and some colleagues did some work of how well decision makers understood this graph, and they had a lot of trouble. You know, for someone who's trained in MP or statistics or public health, it's not much of a problem to see the gap in the bottom and the mean coverage on top, but somehow it was counterintuitive to them that the coverage gap was smaller for the rich than for the poor. Well, actually, it is a gap. It is how far you are from 100%. So it should be smaller among the rich than among the poor. But that led to problems of interpretation. And after we did this small qualitative study, we decided to flip the chart around. And we're still struggling with this issue of how to make it more easier to understand. So the next slide, we show another way of presenting the same information. Next, please. We basically do a bar in which the poor, coverage among the poor is at the red end of the bar, and coverage among the rich is at the blue end of the bar. And next one, please. We flip the bar, and that allows us to compare different trees. I'm sure the size of the font in the y-axis is a bit small, but basically we have a number of countries here in alphabetical order from Azerbaijan to Zimbabwe, and we look at this difference between the richest and the poorest, or Q5, a fifth quintile, minus Q1, first quintile. And this kind of graph has proven to be quite useful and easy to interpret, because you can not only see where the average coverage is, if it's further to the left, let's say Chad, which is sort of the 7 or 8 country from the bottom, you have much lower coverage than most other countries. But at the same time, you see how big the disparities are. So we find this quite useful. It also has a very important policy interpretation from this graph. Next one, please. You can see that several countries here, which have about 50 to 60% overall coverage. Remember, we're talking about the mean coverage of these 8 different indicators: maternal, newborn, and child health indicators. But if you look at these countries, you see, for example, that Zambia, which is the top one, has fairly low inequities. But Guatemala and Madagascar, which is halfway in the chart, they have much larger inequities, although their mean coverage is about the same. So we find that was quite useful to illustrate that even if you have similar levels of mean coverage, we still have a very variable degrees of inequalities. And that definitely raised a number of discussions with country policymakers and international agencies on why are some countries doing better than others. The next one also shows that if we average, next slide please. Oh, one before that. Okay, here we go. This one shows something very similar to what Mickey was saying. You know, the delivery channels for different interventions can actually result in much wider or narrower inequities. So if you look, for example, at vitamin A, which is the third from the top, about 60% coverage in the 38 countries we had data for, and very small inequity. It was probably delivered through campaigns or other community-based strategies. But if you look, for example, skilled attendant or delivery, which is the third one from the bottom, which is traditionally one of the most inequitable interventions we have, the gap between rich and poor is huge. In these 38 countries, the poor are getting 30% of their deliveries with skilled attendant, and the rich over 80%. So we also found this very, very useful, and I think it provides some good background to the issues that were pointed out by Dave and by Mickey before me. Now let's move to a slightly different approach, which we're also using in the countdown, which is what we call co-coverage. And if you look at these bars, the question we're addressing here is how many interventions does each child receive? So we're not looking at average aggregates across the population, but each of these bricks in these columns is one intervention that they should receive and they're not receiving. I think this is a useful approach because it addresses also the...
Uh-oh. Does he know that he's...
Yeah. Okay, I'm back. Are you there?
Yes.
Okay. Let me move quickly before we get disconnected. So I was just mentioning that it addresses the issue of child rights, because every child should be entitled to receiving all of these interventions. And because there are interactions and synergies between some of the interventions, it is also important that they should receive all, not just one or two. So the next slide shows how we did that. We actually selected 9 preventive interventions. We cannot have curative interventions in this index because not every child needs ORT or needs an antibiotic, only those who have had pneumonia in the past couple of weeks before the survey. So we had to focus on preventive interventions. And we are, next please, we stratified them according to wealth quintiles to characterize how well they were reaching our children. Next slide. Lots of numbers in this slide, but let's look at Cambodia. I think that was a survey around 2000. I don't remember the exact date. But if you look at Cambodia, 7% of the Cambodian children in the DHS survey had 0 interventions. That is, they had not received a single intervention of the package essential 9 interventions they should be getting. 16% had 1 intervention, 14 had 2, and so forth. And if you go to the very right, only 1% of children had received all 9 interventions. So how do we graph that, and how do we convey the importance of this to policymakers? The next one, please. Here it is. That's the same information, but that's broken down by wealth quintile. And if you look at the left-hand side column, that's the poorest quintile. You find that almost 20%, the very bottom blue box in there, almost 20% had no intervention whatsoever in the poorest. About another 20% had 1 intervention, and so forth. And as you move right, you see that the number of children who had no interventions goes down, the number of children who had 7, 8, or 9 interventions goes up. And if you just draw the blue line over the 6 or more interventions, and you flip this line, next slide, you get a picture like this. You get that the least poor in Cambodia, I'm not saying the wealthiest, because you can arguably, we're talking about very poor countries, and the 20% on top of the wealth index are not necessarily wealthy, but of the least poor, about 60% had 6 or more of the 9 interventions they should have had. Among the poorest, it's less than 10%. Next one, please. And then we did that for many countries. And we looked at something which we proposed, next please, that there are different patterns. The shape of the curve, can I have the next slide, please? Okay, thanks. The shape of the curve varies. If you have high coverage, and this is the case for Brazil and for Nicaragua, the poor are much worse off than everybody else. So we call that bottom inequity. The bottom group is really the one data point that is not in accordance with the rest. So the line is curved. And if you look at the low coverage countries at the bottom of this graph, you look at Haiti or you look at Cambodia, which you just saw, it's the other pattern. It goes up in the rich and everybody else is much worse off. One more slide now summarizing. And here we have 3 countries. We have Cambodia, we have Philippines, and we have Nicaragua. And there are different strategies here. In a country like Nicaragua or Brazil, which we had in the last slide, you really have to target the poor to make sure that they get up, because everybody else has 80% or more coverage. So there's a real need to target those who are still way behind everyone else in the population. In the middle line, which is Philippines, which is more or less linear, you continue to disseminate widely the intervention, because nobody's at 80% or more, but you do need to give special attention to the poor, or the Philippines will become like Nicaragua, in which the poor will be left way behind. And finally, and I know this is a bit controversial, and Dave Gwatkin always challenges me when I say that, but I'm going to say it again. If you have low overall coverage, like in Cambodia, and the rich are the group that is the outlier in this line, which makes the line curve upwards, then you still need to disseminate interventions pretty widely, because everybody needs them. But at some time, as the line moves up from what it is in Cambodia and becomes something like the red line for Philippines, then you have to start worrying more about equity. So I think this kind of analysis can show us how the shapes of the inequity curves can drive our decisions about delivery channels and about targeting, which is a very important decision. So let me wrap up. I think, next one, please. Okay, sorry, you're a little bit behind me, so do you mind? Okay, now you see the 3 messages that I was trying to put in this slide, which is either disseminate interventions widely, continue to disseminate and give special attention to the poor, the middle line, and target the poor in the top line. Last, I think, I'm really repeating something that Dave just said, which is we talk about missed opportunities for vaccination when a child comes to a facility because it's ill and doesn't get all the vaccines it had to receive. But we also have a lot of missed opportunities for equity work, particularly because we do surveys, we do analysis, we do evaluations, and we don't take the equity dimension into account. It's always possible and useful to include equity in our monitoring, research, and evaluation exercises. However, it has to be planned ahead of time. It's not an afterthought. You have to collect data. Third, which is very important, it does not necessarily require large sample sizes because some of our equity measures are measures which use data from the whole population. So if I'm saying, I have to do quintile analysis, it doesn't mean I need a sample size which is 5 times larger. I can still do pretty well by using summary indices such as the concentration index to size inequalities across the whole continuum of poverty and wealth. By incorporating equity, we may review issues that are not evident in the whole sample analysis, and we can also lead to practical strategies for maximizing the impact of interventions, exactly how Mickey presented so eloquently at the beginning of this session. So I look forward to the discussion. This is the Countdown website, and in particular, if we have some opportunity during the discussion to talk about what's happening in Brazil right now, in which there's a lot of progress being made in terms of reducing inequities, I'll be happy to answer questions on that too. Thank you very much.
Okay, thank you very much, Cesar. Very interesting in terms of thinking how to communicate this at the policy level. Finally, I want to turn to Jennifer Luna, has over 20 years of experience.
Just say that?
Oh, what's that? I just did. Working in international health, including MCH, reproductive health, and HIV/AIDS. At one point in her career, she worked at the USAID directly, and in fact, we were neighbors for a period of time. So I'm going to just turn it over to Jennifer for our last presentation, and talk a little bit about experiences from CSHGP and others.
Get the presentation up. Okay, well, I'm very happy to be here, and I'm really glad to be part of this dialogue about equity because it is an issue that I've been interested in for a long time, because when I did live in Latin America, which was a while ago, I could definitely see a difference between what the wealthier people could get and what the disadvantaged could get. But just like the other panelists have said, we need something practical. It's really nice that there's evidence and people are paying attention to it, but how can we practically do this? So that is the reason that we in MCHIP started to develop this guidance. And I just want to put up some challenges. And this, we geared the guidance first towards community-based programming, but it has wider applications. So I'm going to talk about projects, a little bit smaller scale than the national. And one thing is that a lot of the projects actually state someplace that they're really interested in equity. But then when you start reading the project descriptions, you don't see exactly what they mean by equity or how they're addressing it. The other problem is when you're working with stakeholders, which all these projects and the national programs have, people have different ideas about what equity means, and they may not realize that they have these different ideas. Somebody might only think of poverty and quintile analyses. Somebody might think of geographic. Somebody might think just because you're working in a poor area that you're automatically doing equity, and it's really important to get people on board with that. The other thing, and Cesar talked about missed opportunities, is that you won't know what's happening with equities and inequities if you don't set up an M&E system to measure it. And the other thing with a lot of these activities is that the limited budgets, both for the interventions that you can do on the ground and for ways of measuring it. So it's really important to look for, you have to be strategic in how you do it, and also look for realistic ways, especially in the part of M&E, and it's possible. Okay, and what I just said that, who the, okay, this guidance targets professionals who are designing and implementing projects. And it's a systematic process. We saw one systematic process already with Dave, but it's so that equity is incorporated into project designs, so that improvements can be demonstrated and explained, and so that there's a shared understanding among stakeholders. Okay, and I'm going to just say that this is a definition that we use to base this guidance on, and it's actually MCHIP, what we use in MCHIP. And so health equity is both the improvement of a health outcome of a disadvantaged group, as well as the narrowing of the difference in this health outcome between the advantaged and the disadvantaged group without losing the gains in the advantaged group. So what this has is, this guidance is directed towards improving equity and health outcomes. You have to have a way to compare the disadvantaged group to advantaged group, and you really don't want everyone coming down. I think that's obvious, but we have to say that. I just want to say that the guidance has been developed with a collaborative effort, USAID, MCHIP, CORE, other technical experts. We had a virtual tag where we asked for opinions. Cesar Victoria has been instrumental in reviewing drafts, and I will say there's a literature review. I think pollen is getting to me. Okay, and actually the guidance, it's in development, but it has 3 parts to it. One is the reference document, which actually is posted. It says draft, but it's really usable. We just see it as a living document, so there will be some changes. There's this checklist, which is a series of questions and discussion points for project designs. That's actually almost ready. And a workbook, which is a series of formats for keeping track of decisions. That needs more work. And just what was said before is you can't have a one-size-fits-all for equity, and so this guidance is not a prescriptive approach. So, and it presents a series of concepts that you can take into consideration and make decisions around. Should lead to a coherent health equity strategy for the place that you're working in, and as I said before, it serves as a basis of dialogue among stakeholders. So just because I said before everybody has different ideas about what equity means, we have some guiding principles, some assumptions as part of this guidance. So one of it is addressing equity means more than just working in a disadvantaged location. It means reaching the most disadvantaged within that region and being able to compare the disadvantage with the advantage. Okay, also it requires an understanding of how to handle underlying conditions. And so you have the health outcome inequity, which could be skill attendance at birth, but it also, underlying conditions of low literacy, poverty, geography, you also need to understand that. And just what, this last statement really refers back to what Cesar presented about obtaining high coverage levels depends on decisions made along a continuum. So what the graphs that he was showing of whether you have almost everybody has high coverage but the very poor is different from when almost everybody has low coverage. And so it's important to understand that. Okay, we saw a 5-step process before, and some of the elements of the 5-step process are here, but this happens to be a 6-step process. And I think that's fairly obvious, but it is good to start someplace and be organized about it. So the six parts are: understand the equity issues in the project area, identify the disadvantaged group on which to focus, decide what is in the project's manageable interest to change. You may not be able to do everything. And as was also stated before, define equity goals, objectives, and a project-specific definition of equity. If you don't think it at that level, it's not going to happen. Then strategies and activities, and develop equity-focused M&E so you don't have lost opportunities. And this is just a diagram of of the steps. And one thing about step one, understanding health equity issues, is divided into two parts. The outcomes, which specific things are inequitable, and it's not the same, and I can see Karen sitting back there, it's not the same in all countries. She did some work in Bangladesh to show that I think contraceptives were equitable, but some other interventions were not. Okay, and understand the underlying issues and barriers. And then you can make a decision at that point. Are you able to do detailed equity planning? I think some of our panelists would say, yes, you have to do detailed implementing planning. But if you decide that you can't do detailed equity-focused planning, you still need to keep track of it because it could change over time, or you may really see that you're not going to be effective without doing it. So you still need to have some M&E around it. Okay, and this is the checklist, and I just want to give some highlights because they're really simple questions, a lot of them, but it's just basic things for step one, health outcomes. Do you have quantitative information on specific health outcomes? And it could be DHS, or it could be something from a similar area or something specific in your area. And which are the outcomes? Just state them, identify them. And then look at the magnitude of the differences. So are there gaps that actually justify a special approach? Okay, then the underlying issues and barriers, and it's the same thing. Do you have information? What are the issues? And actually in the guidance, we have a list of underlying conditions and barriers that are very common, like low literacy, mistreatment of population by the health providers. Okay, seems obvious. Have you identified a disadvantaged group? And in this, it may not just be poor. You have to think through other groups, ethnic group, education, place of residence. So, okay. And have you identified an advantage group for comparison? Okay, and then the part about goals and objectives. It's really just making sure that in your goal statement it says something about reducing the gap. And the same thing for objectives. And you need objectives both for health outcomes and underlying conditions if you're going to be changing them. Okay, the other thing that I think is actually important is to have a project-specific operational definition, because the MCHIP, something like the MCHIP definition, which I showed before, is nice, it looks good, but it doesn't really help you communicate what exactly you're doing in your area. And I think you put up a slide before about targeting with immunization. So here it is. It's just actual immunization coverage for children in the disadvantaged ethnic group will increase at least to baseline levels for other ethnic groups in the program area. So you actually know, okay, at the end of the project, well, did I improve equity? Yes, in immunization, I did improve, not just in general. Okay, I want to give some examples of how people this is from the Child Survival and Health Grants program, so they're projects, and how they actually have implemented these steps, although I will say that they were doing this before the guidance came out. We just went back and reviewed and talked to them, but this is to show that it is possible to do this. So I'll start with one project in Ecuador from the Center of Human Services, and they first started out by looking at secondary data, not data they collected themselves. So they looked at provincial data on maternal and child health indicators in the area they were working, and learned that indigenous populations have lower rates of maternal health care utilization than the mestizo, which are the mixed European and indigenous populations. And they also found that the rate of home births among the total population was 46.5, but for the indigenous women, it was almost all of them, 71.4. Then they went and they conducted their own knowledge, practice, and coverage survey in the project area and found the same situation. Okay, and this is another group. This is in Bangladesh and CRWRC, and they first used national data and then they used their own local data and found gaps in knowledge and coverage between highest and lowest wealth quintiles. And just an example of what they found, in the lowest quintile, only 27.3% of women reported consuming iron folate in the last pregnancy versus 57.7%. Okay, now step 1B, understanding underlying issues and barriers. And so in Ecuador, they conducted key informant interviews with traditional birth attendants, and what they found, barriers, cultural differences. Basically, the indigenous population felt that they were being mistreated by people from the health center. They didn't understand their conditions. No confidence in health centers, health workers mistreated. Also geographic distance. So then they actually reviewed national data to see how what they'd found locally compared, and they found that the reason why indigenous families prefer home births, they want to have an active presence of a family member because it provides emotional support. They like use of traditional teas, food, choice of delivery positions, room temperature, clothing, lighting, and they don't want an authoritarian clinician as part of the process. Well, it gives you things to think about. Okay. Another thing that I wanted to say is that you don't actually always have to go to the large statistics. You can also ask the community members who are the disadvantaged. And so, again, CRWRC in Bangladesh used participatory rural appraisal to have the community members identify which were the poorest villages. And you can use a combination of these techniques. Okay, decide what is in the manageable interest to change. Okay, just in an example from Nepal, CARE Nepal found that it was social exclusion of marginalized populations. So they concentrated on including marginalized populations in community level activities, informing them of their rights, and advocating for better treatment by health workers. And with Ecuador, it was also working with health services to improve the cultural responsiveness and using quality assurance methods to bring together community members and the health service providers, that's missing from the slide, so that they could improve services. I think I'm gonna just go to step 6. Okay, this is from CARE Nepal. And basically, they collected data on caste and ethnicity in knowledge, practice, and coverage surveys in order to disaggregate health indicators by marginalized and non-marginalized. They also, as part of the community mobilization strategy, collected community-level data on pregnancy outcomes, and they also disaggregated by marginal and non-marginalized women. And that's the end. So I really am looking forward to a dialogue about this. Thank you.
Well, thank you very much, Jennifer, and all of our panelists. On my run of program that I was given this morning, it says now we have the talk show format with John Borrazzo and panelists, but there's no comfy couch here, so I think and we don't have the whole lot of time. So I do have actually a couple of questions that I'll put out there, but I think I'll put them out in the course of our group discussion. I think the whole point of this format is to really have this be an intimate format in which we really get some discussion going. So let's kick it off to the room, and who'd like to kick off the first question? Okay, so we'll start here on the right side. Can you introduce yourself, please?
Yeah, my name is Fernando Rosenberg. Retired recently from Pan American Health and currently independent consultant and professor. I wanted to refer to the last presentation of Ms. Luna. I think that that's one of the key issues that we face for a while, and we work a lot in terms of how do you make sure that the project preparation is such that, A, it does include evidence-based problems, because I think that that's one of the biggest problems that we have in the health sector, is that we function a lot on the terms of assumptions and not necessarily verifications. And in particular, I think that part of, and I think that one of the questions that I'm sure are going to come up later, but the question of the focalization on one particular group, whether that doesn't end up simply shifting the lack of focalization, if you want, in the next group, because that's one of the problems that we face in a number of countries in Latin America. In other words, you focalize on the poorest of the poor, but then next to the poorest of the poor end up being worse at the poorest of the poor. So how do you deal with the problem? But I think that the main issue here is that how do we ensure that the design of projects and intervention is such that A, is based on evidence, and B, has a weight that one can really verify that it did have an effect at the outcome level. Thank you.
All right, let's get a couple of questions. And it's one of the things that I think brings out is that I think there's a common theme, not just in Jennifer's presentation, but the importance of this issue of measurement as being critical to understanding what the problem is and how we can best address it. In the back.
Good morning, Karen Forright with Futures Group. First of all, thank you for these presentations. They were great. Two observations, which are my particular hobby horses, so I wanted to put them out. One was with the quintile analysis, is the importance of disaggregating, especially by urban-rural, because the quintiles are very highly skewed. So when you do quintile 1, the poorest, you're looking at the poorest of the rural poor, typically. And when you look at quintile 5, you're looking typically at almost all of the urban population. So you'll get some very interesting patterns, and I especially enjoyed seeing Cesar's curves because it's a thing that we've been emphasizing as well in our guidance from measure evaluation. The second is, although health outcomes are where we're going, is I'd like to stress also using client intercepts and other ways of monitoring your uptake of the intervention along the way, so you don't have to wait until 5 years or 3 years or even 1 year. And if your interventions are not being selective, which are supposed to be pro-poor or pro-particular caste group or ethnic group, are not being taken up by those target groups, your priority groups, if you find a difference later on, it's probably by accident.
Okay. Anything else on the floor? Okay, David?
I guess just building on
Introduce yourself, David.
David Wu from Save the Children. Just building on this issue around universal coverage versus a more focused approach. And I know it's a long-standing debate. Dave, you made your views known on this previously, but it seems to me at the end of the day, it is important. I mean, these are strategic choices, and so I think having your thoughts about that. Related to this is, and particularly I guess this is directed to Dave, you've been a champion for this issue for, I don't know, 40 or 50 years? No, maybe not that long. Let's say 10 or 20. You know, why only now is it seeming to get some traction? I'm just curious because it seems like such an obvious missed opportunity for over an extended period of time. Why now, in your view?
So why don't we leave it at that for the moment? I'll just add one comment that picks up a little bit on David's question, which is that what's been laid out in terms of both for Cesar, who's trying to figure out the best ways to communicate this to policymakers, and then for you, Mickey, in terms of the dialogue that's taking place around this issue at country level, does this seem to have resonance? Is this something which is our country is going to essentially say, yes, we do need to do this, and how? And then the question is, as a practical matter, how have they been coming back and saying we are going to do it? Okay, so why don't we pick up on those questions and then go for a second round? So who wants to begin?
Which question?
Well, there was some comments initially that were addressed to you, Jennifer. I'm not sure if there was a question there, but it definitely, if you would like to respond in any way. There was a question that went specifically to Dave, and then one that really picks up on a little bit cross-cutting.
Well, actually, what I can say for the comment over there is I appreciate the opinion. I think what was really important was that you have to monitor this over time because it'll change. And what he's pointing out, okay, you focus everything on the poorest of the poor. Well, maybe there's another group. So you really do have to keep your eyes open, and you need to be proactive in setting that up. So that's what I'd say. I also agree with the comment about if you're doing quintile analysis, separating rural from urban, you get different patterns, and I've seen the work that Karen Forright has done on this. So those are two things that I think were directed mostly to me.
Okay. And so, Dave, based on your nearly half century of experience in this issue, what would you have to say?
2 points. Why is it gaining traction now? My sense is it's really because of the lack of political implications of it, the lack of political pressure. I've never heard of I've heard of many ministers get fired because some hospital treatment goes wrong or their nurses go on strike. I've never heard of a minister getting fired because some poor kids out in the back of the beyond end up dying when they didn't have to. So I think it's really a political economy question. On the question of country responses, I'll be very interested in Mickey's response to this one on how the UNICEF country offices, what you're hearing from them. I've just begun getting into country work, and I'm just finding country attitudes all over their place. There's some that talk a good line and don't do anything. There are some that really don't say much about it and do something, and Ethiopia is an example there. If you read their plan, you don't find anything about equity, but they've introduced this health service extension worker program. It's probably pretty pro-poor. And then there are countries that do both, talk a good line and actually do something, and I think Nepal is probably a pretty good example of that. My guess is that we would find equal distribution, disparity all across the board on how countries are responding.
Thanks, and that's a good typology, I suppose. Obviously, we're finding with the events in the Middle East and ruling elites now recognizing that they cannot continue to ignore the challenges of spreading the welfare impacts to the larger parts of the population. It is gaining more traction, partly because of that. It's also partly because of the case that we're trying to make more, and it has getting traction, that focusing on populations which have been previously neglected can be cost effective and accelerate progress. And there we've had debates about the MDGs and whether they're a good or a bad thing to happen. And here, I think our sense is that there is now increasing political pressures on ruling elites to at least be seen to be trying to achieve the MDGs or make progress towards the MDGs, and therefore the focus on equity and reaching those and being able to show that will accelerate progress has an attraction to some leaders. The other point to make, which is a corollary of what Dave just said, is that in fact most countries will point out that they have got equity on the books, and in terms of policies, in terms of regulations, in terms of the rhetoric, nearly all countries have it on their books, and what the difference is one is the actual implementation, but that's quite closely linked obviously to the amount of personal political capital leaders give to the issue, but also to the functioning of the how much it's in the the Nigerias and the Ghana, the countries, the big countries in this world. It's really about what's happening outside of the capital cities and what happens in the actual implementation and decentralized level, which makes the difference at the end of the day. So what many leaders are saying, well, yeah, we have it, we're doing it, we say we have it on our books, we have budget lines for it. But the real challenge is the fact that the capacity, the implementation capacity, is inversely proportional to the need, and that's where the challenge lies.
Cesar, I want to give you an opportunity to comment on. Maybe you'd like to comment on the question that was raised from the floor around looking at some of these urban-rural differences, or what the experience you mentioned in your remarks.
Yes, well, thank you. There are a number of good questions. I just wanted to, because we don't have that much time, I just wanted to focus, and also because I'm being switched off every 10 minutes, exactly every 10 minutes. So I have 1.5 minutes now before that happens. I think the issue here is we often see targeting and universal coverage as being opposites or alternative approaches. And what we really had in a country like Brazil, where overall coverage was already reasonably high, was that targeting the poorest, particularly with the family health program, which was deployed in the poorest municipalities in the rural areas and in the urban slums, starting in 1994, that really led to great improvement. And it was a strategy for reaching universal coverage. So if you look at what we had in Brazil 10 years ago or 15 years ago, 70% of the poorest quintile were delivering their babies in a hospital, compared to 100% of the richest. and now it's 97% in the poorest, and the richest are still 100%. So I think these are not incompatible ideas. You can effectively use geographic and socioeconomic targeting to ensure that universal coverage is achieved throughout the population. Obviously, you only do that if you have sufficiently high coverage and if you have a bottom inequity pattern like the one I showed you in one of the slides. But I don't get that they are necessarily opposites. They can be complementary, and targeting is a strategy to reach coverage for all mothers and children. Thank you.
Okay, thanks. Let's go to the next round. Let's go and take another round of questions. Nazim.
Naza Qureshi, USAID. As a part of the Global Health Initiative as well as USAID Forward, there is emphasis on the principle of innovation and research. And grand challenges may also be framed with the equity lens and consideration. But I was curious to know from the panel if there are opportunities that either USAID is creating or investing in, as well as other donors as well, that provide an opportunity to link smaller scale research and process documentation with broader national policy and strategy concerns. What would the panel place high on an agenda for evidence building and lesson learning around equity?
Okay. So what some of the research questions? Next. On the left, go ahead.
Hi, good morning. Claudia Morrissey with Save the Children. Very interested in this notion that we need to set targets and, of course, measure those targets. And I'm wondering about the concept of the national evaluation plans that is being put forward in certain circles, whether or not you see this as a mechanism by which it can enhance measuring these equity goals, or whether it might obfuscate us looking at the equity goals.
And this round, Liz.
Hi, I'm Elizabeth Schenecker from USAID. Great presentations. I got so many practical, useful ideas. Thank you very much. I was wondering if you would comment just a little bit on what indicators you have found particularly useful for measuring inequalities in family planning. I saw a mention, I think, on one of the slides of unmet need, but of course unmet need is kind of a moving target, particularly when contraceptive prevalence is low. So I'd just be interested in what you think are good indicators for measuring that.
And then one more.
Okay, good morning. My name is Abdelhadi Al-Tahir, Senior Advisor for Maternal Newborn Health with Pathfinder International. I would like to thank the panelists for the excellent presentations and very informative. I have a question for Dr. Mikey about your slides have really shown significant reduction in under 5 under 5 mortality, but it seems that there is no equivalent maternal mortality reduction in, especially in the area of Southeast Asia and Sub-Saharan Africa. But in your slide, you mentioned UNICEF somehow focusing on emergency obstetric care as one of the parameters. But if there is an effective intervention in that area that could have led to some sort of reduction of maternal mortality, would you please comment on that, in addition to the linkage with reduction of neonatal and stillbirth as well? Thank you so much.
All right, well, we'll go with those for now. So we've got first just the general question from Nazo on what are specific areas might be ripe for evidence building in terms of understanding what we need, what kinds of tools we might need to do a better job in terms of some of this equity targeting. So do you want?
Go ahead.
Well, I'll do Marcy and this last one as well together. As I've suggested in my talk there, I think what we're trying to hone in on is are particularly innovations and research which can help to overcome the bottlenecks for the poor for each of those delivery channels, so some of that will be within those specific delivery channels. For example, access to skilled delivery. we would prioritize innovations that will improve referral between primary to secondary or tertiary level. We would prioritize demand-creating types of interventions, conditional cash transfers being perhaps the most obvious one there, and of course the quality issue that, one of the biggest inequities we see is the difference in quality of care between the rich and poor, even when they get to a service. And then obviously the other ones would be the shift between one channel to another, and that's where the work we're doing with many of you around community case management, task shifting, and how do we do that at scale and get sustained quality. And in particular, some of the critical bottlenecks that we're seeing there are around financial sustainability and supply chain management to community-based workers in particular. So innovation and research, operational research around those things. But like I said, I think what this is helping us to do is to give us a framework and a prioritization process about which kinds of innovations and research are important. With respect to maternal mortality, I think some of the latest estimates are showing quite significant drops, particularly in South Asia and Southeast Asia. Africa is still lagging behind, though still also showing some drops in mortality. It's an area which we're going to take up later in the maternal review, and just to give away some of the points I'm going to be making there, I think it is very context-specific. So in particular, I think in Africa, HIV is obviously a critical issue. And we must continue to scale up and improve access to diagnosis and treatment there. But I do think that the challenge of the reality of women, the majority of women who die and the majority of women who deliver are dying and delivering outside of facilities is our starting point there. And how do we, and this is where we're trying to get UNICEF country offices to focus more on, is how do we start to look at innovations of either getting women into facilities, either through compensating for their costs or setting up, transport services, and or waiting homes, maternity waiting. We need to be focusing much more attention to the nuts and bolts at a country level than just come. And this is really Dave's point. Instead of just having some sort of unitary policy prescriptions, and this is where, so I have no glib answer for you in terms of, we've been doing a lot of the EMOC assessments to really look at the distribution of services in countries, to look at where the shortcomings are, and that's the starting point for creative problem solving, and that's the capacity we need to build and the culture we need to build within the key countries.
Dave, you have some comments?
I'll handle two questions. What research topics? My hobby horse is just getting simple monitoring and evaluation done. I think my guess is, particularly if these interventions we think are really reaching the poor and good, I think it can have one of two outcomes. First of all, it's often going to tell program managers are not doing nearly as well as they think they are, and that prompt them to do better. And second, there may be some cases that are really working quite well, and if so, we need to do that now. So I'd go not for this high-end stuff that's attracting the attention of the econometricians, but the $10,000 simple evaluation. I've been making Save the Children's. David's been making my life miserable on this universal care. I've been making Save the Children's life miserable and yelling and screaming about doing that. They ought to be doing this kind of thing. We've actually been discussing it. It's beginning to move in that direction. So anyway, there's my topic. Second, on family planning indicators, I think unmet need is a pretty good one. I used to use contraceptive prevalence. And what that doesn't get at is separate out the demand and the supply issue. I frankly was under the impression that really in low-income groups, low contraceptive prevalence was a reflection of low demand or high fertility preferences. But lo and behold, when you really look at this by fertility, by quintile, look at demand, unmet need, even that turns out to be higher. So you have a supply issue at the at the low end as well as the high end of the economic spectrum, and that makes life a lot easier because it's a lot easier to do something about your supplies than about your demand. So yeah, unmet need seems to be to work fine.
Yeah, I can add, especially the part about evidence building and taking the small to large scale, and the child survival and health grants that I use as examples actually will produce data. There are simple techniques, and I really think that the challenge is to get these smaller experiences. First, they need to be organized and collecting information, but link them to the larger processes so that their lessons learned are actually paid attention to, and it's a communication, I think, challenge.
Cesar, I don't want to forget about you on the video there before you get cut off again.
He's cut off.
Okay, very quickly, I think the questions have been properly answered. I just want to make a couple of comments on the national evaluation plans or national evaluation platforms, which some of us are involved in. I think they're really excellent approach to measuring equity, because by looking at all districts in the country and trying to understand what's happening in the country as a whole, we can detect where programs are going and where programs are failing to reach. So at that geographical level, at the very least, we can look at inequities in a very, very simple way. We did that for IMCI in Tanzania, Peru, and Brazil, and we found that one of the strongest drivers where IMCI was implemented was distance from the capital. If the district was closer to the capital, you would get IMCI. If it was far from the capital, its chances of getting IMCI were much, much lower. So I think it's that kind of a national approach to evaluation in which one is looking at all districts in the country and at several programs instead of one, can be really helpful in terms of understanding issues related to equity at a very low cost, because the information is there. It's a secondary data existing from different data sources that are just pulled in a single national evaluation platform. Thank you.
Well, thank you. We have time probably for one more question from the floor. One or two. Okay, so Mary and Karen, I think, are going to be it.
Thank you. Mary Carnell from JSI. Thank you all, really, for excellent presentations. I appreciate the practicality. I'm trying to look I'm just trying to understand a little better. I guess I've been working many years with rural poor and urban poor and thinking I was doing my work without measuring the quintiles. And now when we get to the rural poor, it seems, as we're speaking, Karen was speaking earlier, on the national evaluation, they're going to a lot of the rural will be in the lower quintiles. Are you suggesting when we refocus to looking at the subsets of the rural apart, that we have a different set of indicators so that they have their own set of 5 quintiles? Or are we just lumping them, because a lot of them would lump in the lowest? I'm a little confused there. And again, tied to that question is the question of sample size. I'm a little confused on whether the sample size, I would think it would need the 5 strata, and so that you have to multiply it by 5, and it sounds like Victor has a way to do it with a smaller sample size and still get statistically robust data. So I'd be interested in that too. Thank you.
Okay, and then the last question.
Thank you for excellent presentations. I'm Karen Laban with the Core Group. I just wanted to go back to Dr. Chopra's presentation at the beginning about closing the uptake gap. We talked a lot about delivery systems. We talked about the policy changes needed, but we didn't really address demand empowerment as much. And I'm just curious what indicators are being used to look at this, how it's very important to sustainability, capacity building, especially in poor rural areas.
Thanks, Karen. And as I said in my talk, it's an area which because this work was originally to frame a literature review, which we've completed, to look at what were the strategies to improve uptake and access to these critical interventions. And I must say, as you're probably aware, the robust evidence base for improving demand side things is very thin, because it's quite often done as sort of local NGO and local capacity building, and not often done as a sort of trial basis and that sort of thing. So we are grappling with how do we systematically make recommendations for improving demand side aspects and empowerment. And it is an indictment of UNICEF. Because that's an area which we've traditionally done a lot of our, has been the basis of a lot of our programming. And so we are, in terms of the, well, first is to encourage a much more rigorous approach to this area than we've done in the past. And secondly, as part and parcel of that will be to then start to measure how do we measure these very difficult concepts of empowerment, of capacity, and so forth. I haven't got time to go into the details. What I can say, though, is that very much in line with what Jennifer and David and Cesar have been talking about, is that we are, in partnership with you all in the room, really talking to our country officers, not just about developing the evidence base, but also talking about scale. And in particular, this idea of contacts and touches, or whatever we call it, and how do we start to more rigorously define norms and standards for these kinds of things. We've just finished doing a trial which will be published in The Lancet very shortly on breastfeeding, which showed that 5 contacts between a lay worker and a mother during pregnancy and delivery increased exclusive breastfeeding by 20-30%. So, can we start to put that evidence together and start to have a framework for which we can monitor against and have some sort of and do some planning against? And that's, that's the challenge we're facing, is planning for scale. For some people, though, that's too instrumental and too narrow. But I think it's a starting point to at least start to say, what is the human infrastructure we need to get these demand side things going?
Last set of comments.
Is Cesar there for the sample size? Is he with us still?
Cesar, you want to comment on the sample size question that was raised?
Sure. Actually, when we think of equity analysis, we often think that we want a separate estimate for each quintile. And ideally, that's what we want. And if we want that, we need a fairly large sample size, because we need enough for mothers and children. Each quintile should give a precise number. However, there's a lot of progress in summarizing inequalities across the whole range. And these include not only the concentration indexes, which have been around for quite a while, but something which is in the guidelines that were referred to earlier on today, which is the slope index of inequality, which basically one uses a regression analysis to show how far the rich are from the poor by taking all the data in the whole distribution. So there are effective ways of doing that. I just wanted to end by saying that the issue of asset indices is interesting in terms of these assets that are measured wealth are mostly, they're urban biased. So we tend to have televisions and radios and motorcycles and whatnot. And often we find that if we are separating urban from rural populations, the types of assets are quite different, and what means which issues belongings that imply wealth in an urban area are not the same that are associated with wealth in a rural area. So there's a lot of work to be done there. I think our indices are really urban biased, and I think that by comparing quintiles without considering urban-rural stratification, we are missing a big part of the difference. Well, we're trying to work on that in the Countdown Equity Group, in which we actually have access to the raw data in all DHS and MICs that have been conducted in the last 20 years. And we're exploring new approaches for that, but some of our colleagues have already done some work on that. And it's, I'm sure there'll be a lot of progress in this respect in the next couple of years. Thank you.
Any wrap-up comments, Jennifer, Dave, Jennifer?
Well, I can add to the quintile is that you don't always have to have 5 parts. You could divide it into 3 or lower, and we're looking into ways of using national quintile information, but make it available locally. I don't know, Alex, do you want to say anything? You're the one talking about it. he's working on some ways to simplify it so that it can be done either through exit, the intercept interviews. Karen, you want to say something?
Yeah, just a quick thing. Any national survey is going to have, excuse me, any national survey, a DHS or a mix, is going to have enough sample size to do it separately for urban and rural. You can use the wealth score in the DHS, which is part of the standard recode file, and just reclassify, stratify urban, rural, and then just re-rank them. One of our rules of thumb is if your wealthiest rural quintile is no better or worse than your poorest urban quintile, forget about doing wealth pro-poor in rural areas and just go to a generalized rural strategy. It's a really easy index to use.
All right, well, thank you very much. First, thanks to our 4 presenters. These were, in fact, stimulating and great presentations. Thanks to the MCHIP staff who organized this event. It was great to get us all together. I hope that we've all been able to take something away from this. The purpose of the event, obviously, is not the event itself. The purpose of the event is to take something away that we actually can start to think about and use in our work. And I think that we've had some good discussion today about this interface, about policy, how this influences how it can have influence at the policy level, programmatic level, at the project level, and looking at and we're all working at those different levels. So hopefully we can all take something away for that. Clearly, the discussion we've had about the importance of analysis and continuing to build the evidence base and monitoring and monitoring as well as measurement as being critical to making progress in equity has been, I think, an emerging theme. Finally, I want to make sure that we've thanked our hosts, the Woodrow Wilson Center, and on behalf of USAID and our Maternal and Child Health Integrated Program, MCHIP. Thanks again for coming out this morning and being here. So thank you very much. Thanks again, Jeff. Bye-bye.